Improving patient-physician communication. Teaching practitioners how to communicate. The absence of concrete advice for physicians may have been due to 1. The belief that bedside manner, or the art of medicine, was something you either had or didn't have. There had been much effort to find personality traits that could discriminate sensitive from insensitive physicians. The goal was to include these as criteria in med school admissions. There was only one reliable predictor: the would-be physician's indication of an interest in people. 2. Belief that effective communication may interfere with the ability to be competent because the person would not be tough enough. 3. Feeling that physicians have enough difficulty staying on top of the technical side of medical care without becoming emotional specialists. Patient-physician communication implications for the Internet. From approximately 7 million users in 1996, the number of people who regularly use the Internet to search for healthcare information climbed to 25 million in 1999 and had reached 37 million by May of 2000. Patients who access authoritative medical information also visit emergency rooms and doctors' offices less. What could be the pros and cons of this phenomenon? Reducing non-adherence. Non-adherence can be reduced by implementing changes through institutional innovations, presentation of treatment regimen, and practitioner communication skills. Adherence to appointments can be improved with postcards or phone calls. Efforts to decrease waiting time before the patient receives services improves the rate of follow-through on appointments. Recommendations should be written down. Patients should be tested for understanding. Information is given about dosage, side effects, etc. Pill packaging is designed to aid in recall. Practitioners should avoid jargon. Provide clear explanations of what the problem is and what the treatment will be. Provide attention to what is distressing the patient, not just the clinical symptoms. Provide feedback on the patient's questions. Highlight advantages to adhering, downplay disadvantages, and stress disadvantages of non-adherence. For vocational and social advice, special measures are needed. For example, provide concrete examples of the stress-illness relation. List stressful situations and problem solve together how these can be avoided or minimized. Get verbal commitment by the patient. Promise that recommendation will be taken. Practitioner can probe for potential sources of resistance to advice. Pain is the symptom most likely to lead individuals to seek treatment. The Institute of Medicine estimates that chronic pain affects 116 million Americans. But the relationship between pain and symptom severity can be weak. For example, a cancerous lump may not be painful in early stages, but it is of great medical importance. When patients are asked what they fear most about illness and treatment, the common response is pain. Note, pain's function as a warning system is important. Those born without the ability to feel pain have either congenital analgesia or congenital insensitivity to pain with anhidrosis, CIPA, in other words, familial dysautonomia. These individuals can't feel pain when they cut or scrape themselves, leading to risk of infection. Those with CIPA have an additional disruption in body's heat-cold sensing perspiration system, anhidrosis, so the person is unable to cool off by sweating. The loss of pain sensitivity can be acquired later in life. Some conditions, diabetes, can cause neuropathies that block pain sensations arising from extremities. These individuals may not notice damage and may lead to more intrusive intervention. For example, a toe may need to be amputated. The importance of appraisal. Pain perception occurs through nociception, the activation of specialized nerve fibers that signal occurrence of tissue damage. The degree to which it is felt and how incapacitating it is depends to a large extent on how it is interpreted. Beecher, a physician, was one of the first to recognize this. In treating soldiers during World War II, he noticed that only 1/4 requested morphine for what were often severe wounds. When he returned to civilian practice in Boston, 80% of patients appeared to be in substantial pain and demanded painkillers. Pain for soldier meant he was alive. To the civilian, the pain was an unpleasant interruption. There are similar examples with athletes. Have you ever gotten hurt during a sporting activity and not noticed until after? This may be caused by sympathetic arousal in response to vigorous sports that seems to diminish pain sensitivity. Beecher described pain as a two-dimensional experience, sensory experience and emotional component. The environment also seems to affect the appraisal of pain. Ulrich in 1984 found that patients recovering from gallbladder surgery differed in how much pain they experienced based on the view from the hospital bed. Those whose windows faced greenery or trees requested significantly fewer painkillers than those with no view. Some measures of pain are self-report, McGill Pain Questionnaire, most widely used, physiological, and observational measures. Two different types of pain, acute versus chronic. Acute usually results from some specific injury that produces tissue damage, like a wound or a broken limb. According to Keefe in 1982, is usually adaptive and usually lasts less than 6 months. Chronic usually begins with an acute episode. Unlike acute, it does not decrease with treatment and time. Chronic pain is frequently experienced in the absence of any detectable tissue damage. Approximately 90 million Americans suffer from chronic pain at any given time. We can further discuss pain in terms of the presence or absence of tissue damage. Organic pain is related to tissue damage. Psychogenic pain has no apparent tissue damage. It is important to be aware of selection biases in pain research. It is not sound to generalize findings from pain clinic samples to the general population of pain sufferers. The bias towards neuroticism is likely present in any specialized clinic population. Also, differential referral is likely to create bias in pain clinic populations, because general practitioners and other specialists are more likely to refer a difficult, emotionally disturbed patient to a pain clinic. Why is the distinction between chronic and acute pain important? They present different psychological profiles. Chronic often entails psychological distress that complicates the diagnosis and treatment. Depression is common among chronic pain patients and may exacerbate pain and pain-related behaviors. Kinney in 1993 found that patients suffering from chronic low back pain reported higher rates of psychopathology than those with acute low back pain and much higher rates than pain-free individuals. Chronic pain sufferers are more likely to be depressed, abuse alcohol and drugs, and have personality disorders. They also found that chronic pain patients had high rates of psychopathology before inception of pain. Many pain control techniques work well to control acute but not chronic pain. Chronic pain requires individualized multiple techniques. As an example would be that acupuncture is often effective for acute pain patients. Chronic pain management is more complex. Chronic pain may derive from a predisposition to respond to bodily insult with specific responses, such as tensing the jaw or tightening the muscles. Because of their pain, they may be more susceptible to stress, further compromising their ability to cope. The pain-prone personality is considered too simplistic. Why? Pain can produce at least temporary alterations in personality. Personality variables associated with pain could be consequences of pain, not causes of it. Think how different you act when you are not feeling well because you're in pain. Individual experiences of pain are too varied and complex to be boiled down to single personality profiles. Researchers have tried to identify subgroups rather than develop profiles that will explain all pain behaviors. They've relied on personality inventories, such as Minnesota Multiphasic Personality Inventory. This inventory reliably distinguishes acute pain patients from chronic pain patients. Those suffering from acute pain have elevated scores on 2 scales within the inventory: hypochondriasis and hysteria. Chronic pain patients have elevated scores on 3 scales, referred to as the neurotic triad because it often shows up in personality profiles of patients with neurotic disorders: hypochondriasis, hysteria, and depression. Gender differences in pain. There is no consensus on the existence or nature of sex differences in response to noxious stimuli, but women report pain more readily than men. Compared to men, women have reported greater pain from pressure and electrical stimulation, less pain from heat, greater number of sites of pain, higher postoperative pain following third molar extraction, more frequent chronic pain complaints, more frequent use of analgesic meds, higher prevalence of migraines, non-migrainous headaches, higher prevalence of back pain. But gender differences are less likely to be seen among athletes. Lab pain responses. Overall, females exhibit greater sensitivity to lab pain. These gender differences do not appear to be site-specific. Some forms of pain stimuli have produced more consistent findings than others. For example, females consistently more sensitive to pressure than thermal pain, similar to those in the natural environment. Sources of variability in gender differences. Sex of the researcher. One study found males report less pain to females. Another study found no differences. Body size. No studies have supported this. Menstrual cycle. No consistent effect has been found. Male stoicism. The researcher Butte does not think this accounts for the gap, given so many studies find differences. Hormonal differences. Headache and abdominal pain diminish after menopause. Dimensions of the pain response and gender differences. Sensory intensity versus affective unpleasantness. Cognitive evaluative appraisal. Physiological, behavioral. It is not known which aspects of the pain response differ according to gender. Different pain induction and measurement procedures are differentially sensitive to these various pain dimensions. Example: more prolonged cold stimuli tend to elicit higher affective responses compared to sensory responses. Age. Certain pains tend to increase in frequency with age, especially headaches, facial pain, and abdominal pain. In a survey of 25 to 74-year-olds, those over 56 were twice as likely as the 25 to 45-year-olds to have experienced 2 or more pain episodes during the previous month, and 3 times as likely to have had 5 or more episodes. Those over 65 who reported a greater sense of overall well-being complained less about pain than those in other age groups. Ethnic differences. Most research compares African Americans and European Americans. Overall, there is a greater sensitivity to experienced pain stimuli among African Americans compared with European Americans. It is hard to compare across studies because they use different pain measures. Ethnic identity may be more important than ethnic status per se.